All right, it's just about 8 o'clock. Dr. Forkey, if you're ready, I think we will launch in. Good evening. Thank you everyone for joining us tonight. My name is Ashley Popoli. I'm the statewide director for the KidsNet program, and I know that I speak for myself and all of the KidsNet staff and the staff at MSPCC when I say welcome, and we're really thrilled that Dr. Heather Forkey is joining us tonight. And she is going to help us cut through all of the news that we've all been incessantly consuming, I'm sure, to give us some straightforward and practical tips on how to think about and manage COVID-19 in our families. Before we launch in, I just wanted to mention a few housekeeping things. So we are recording tonight's presentation. It will be available later on the KidsNet and MSPCC website. So for that reason, we wanted to make you all aware, but also to encourage you to use the Q&A function that you see at the bottom of your screen. Those questions that you send in will only be visible to Dr. Forkey and to myself. And you have the option to send them anonymously if you'd like, given the fact that we're recording, but we really want to encourage you to use that function and really make the most of Dr. Forkey's time with us. So as you think of things, as Dr. Forkey's presenting, go ahead and send us some questions, and Dr. Forkey will be spending some time midway through and after the presentation answering them. So please don't hesitate to do that. And I guess I'll launch in. So without further ado, many of you know Dr. Forkey and her work, but for those of you who don't, I just want to share with you that Dr. Forkey is an associate professor of pediatrics at the University of Massachusetts Medical School, and she's the division director of the Child Protection Program and the Foster Children Evaluation Service of UMass Memorial Children's Medical Center, the FACES Clinic. In addition to the clinical work that she does there, Dr. Forkey's been the recipient of local and federal grants to address the issues specific to children in foster care and to translate promising practices to address physical and mental health needs of children who have been traumatized. She's published and presents nationally and internationally on these topics. She serves on the steering committee and multiple other roles for the National Child Traumatic Stress Network and provides leadership for the American Academy of Pediatrics on issues related to foster care and child trauma. So for that reason, we're really thrilled that she's here with us tonight to share with us some information that we know will be useful to you as you continue to navigate through this new environment that we're in. So Dr. Forkey, to you, take it away.
All right, can you guys hear me? The first step. Okay, good. All right. So I'll start with my slides here, and we'll kind of just give you a little overview of what I'm going to talk about tonight. Is we're going to start with what do we know about COVID-19 and COVID-19 in kids, and what are some of the issues to think about now, and what are the ways to be ready to address health when COVID closures are over. And then at the end of the presentation, I want to just talk about health issues to be aware of for kids who are in foster care now and later, and how you can work with the doctor for the best outcomes. You know, I have to start by just being really honest that it is a confusing time. It's confusing for you. It's confusing also for the medical providers who are at the hospitals and in our offices. You know, everything is conflicting. So for instance, when we first came out, they said, you must not leave the house for any reason, unless of course you have a reason, and then you must leave the house. And all the stores are closed except those that are going to stay open. And all stores must stay closed unless they need to be open. You know, everything that we say has this and then the opposite. So of course, we've got these big stay-at-home orders. Today, the governor announced that we're going to gradually come out of the stay-at-home orders. But we've also been told at the very same time that you must stay home, you must stay home. And of course, how many times do I have to say it? You must go outside for your mental health. And so go outside, but of course, don't go near anybody while you are outside, and don't go to a park. So everything that we're talking about is kind of conflicting. So let's see what we do know, what we can say, what is clear. COVID-19, the name comes from the words coronavirus disease. That's where COVID comes from. And the fact that it was first identified in 2019 gives you the 19 on that. And that's a name that came from the World Health Organization, or the WHO. Let's see, I can get this to advance. You know, a lot of times the comparison that you'll hear about COVID is this comparison to the flu. And COVID is actually caused by a type of virus called the coronaviruses. As I mentioned in the last slide, coronaviruses are a family of viruses that are not influenza viruses. They're different. Coronaviruses in general cause pretty mild illness. Most of them are colds. Of course, there are some very serious COVID viruses. The one that cause sudden acute respiratory syndrome, or SARS, is a COVID virus. And there's another one called Middle East respiratory virus, or MERS. Those are both coronaviruses that are pretty serious. But because this particularly acts a little bit like the flu, we've been comparing it to the flu. So let me show you what we have in terms of direct comparisons to the flu. One of the first things that gets compared is what's called the R0 number, and that's the estimate of how many people are infected by an average individual with the disease. When we're talking about the flu, on average, for every person that gets the flu, they're likely to infect 1.3 other people. COVID appears to infect more, so it's 2 to 2.4. All of these numbers are changing as we get a better handle on how many people have actually had it, how many people have it and are not symptomatic. But these are the best numbers that we've got going so far. So what this is telling us is that COVID appears to spread more easily than the flu. The incubation period has something to do with that. Now, the incubation period is the time between being exposed to having the disease and when you start to feel sick. And that's an important period of time because you can have it and be spreading it before you feel sick, before you immediately sequester yourself because you're in bed. And so the flu, it's only 1 to 4 days from the moment you get infected to when you're in bed sick. The max is 4 days. So you're not out spreading it for a long period of time. COVID can be up to 14 days that you can go on and it's kind of brewing in your body, but you don't know. And that's why when we've talked about quarantine, the quarantine period is 14 days, because we know that from the moment you've been exposed, if you're going to get any symptoms, we're going to see them within 14 days. What about the hospitalization rate? How many people who get the disease will need the hospital level of support? For flu, it's 2%. For COVID, this is a tricky number for us to figure out. It appears to be between 5 and 19%. And that has to do with us figuring out how many people have had it in the community. And it appears to be different for different communities. So certainly the elderly, people who have pretty other underlying conditions, their risk of being hospitalized is obviously much higher than other people. And then there's the issue of the case fatality rate, the percentage of people who die from this out of all the reported cases. Again, that relates also to how many total cases we have, and that number does keep changing. So these numbers keep changing, but you'll see that there's a significance to these numbers that's important. For flu, it's 0.1%. Whereas for COVID, it looks like it's around 1 to 3%. So at least 10 times more likely for you to have a fatality from COVID than from influenza, which is why we're taking it so very seriously. Let's see, the slides are. Now, the next question is, what are the symptoms that you should be looking for? And since the get-go, we've been hearing about these symptoms. Look for fever, look for cough, look for shortness of breath. And the truth is that about 2 weeks ago, the CDC added 6 more symptoms to that list. They added chills, repeated shaking with chills, muscle pain, headache, sore throat, and that new loss of taste or smell. In kids, however, it appears that kids are less likely to get the infection at all. And so what we're thinking is that for most kids, when they catch it, we either see a very mild illness, or what we're finding is that when we do test kids, they're not showing any symptoms at all. So there was a study that came out just about 2 weeks ago that looked at all the studies that had been done previously on children, which means that they took about 30 studies looking at kids and adolescents infected with SARS-CoV-2, which is the other name for COVID-19. And they looked at those who were testing positive, and they found that for children, the symptoms most likely were fever, dry cough, fatigue, and then sometimes with this nasal congestion and runny nose. Tricky because kids a lot of the time have nasal congestion and runny nose from viruses or from allergies, from all sorts of reasons. You've also probably been hearing that sometimes people present with gastrointestinal symptoms, much less likely in adults. In babies, we were seeing some nausea, vomiting, and diarrhea. But more recently, like within the past week, we've started hearing about this Kawasaki-like illness, which is called pediatric multisystem inflammatory syndrome. And the news is covering this with a vengeance. And I have to share with you that Kawasaki disease is something that your pediatrician is familiar with. This is not something you may know about, but we as pediatricians are actually always on the lookout for this. This is a complication from a lot of viral illnesses that we see most often in kids who are less than 5, and it's more common in kids, in boys than girls. But your doctor actually has always been paying attention to your kids, looking for whether an illness has turned into Kawasaki's disease. So we're not particularly shocked to hear that COVID-19 could also lead to this Kawasaki's-like illness. And so we are actually in pediatrics not completely taken off guard by this. It's also still exceedingly rare. It's exceedingly rare with other viruses, but it's also exceedingly rare with COVID-19. And so, yes, there have been a couple fatalities. Kawasaki's can be rarely fatal, but it is also extremely rare. And we've seen less than 100 cases that we know of in the United States at all. So while it's popping up, and it's something for us as pediatricians to keep in mind and you to be looking out for in the back of your head, it's not something you get too wildly upset about. Really, almost every virus can lead to this type of syndrome. And what you're looking for with Kawasaki's is a fever over 102 for 5 days. We see these red cracked lips and what we call a strawberry tongue. We see a rash over all parts of the body, but particularly on the hands and feet. And we see these red bloodshot eyes that are the common symptoms that we see. So what can you do to prevent all this? And honestly, what I have to tell you, you've already heard. Keeping your hands, washing them often with soap and water for at least 20 seconds, avoiding touching your eyes, nose, and mouth, because this is a respiratory infection. It comes into your body through your eyes, nose, and mouth. You know, one of the other misunderstandings about COVID-19 is people think that it lasts in the air, or it's what's called aerosolized. COVID comes through the air through respiratory droplets. That's what comes out of your mouth as you cough, sneeze, or talk. But respiratory droplets are heavy and they fall to surfaces or the floor. And so they don't just hang out in the air. It's most often from surfaces or from having the respiratory droplets hit you. So covering your cough or sneeze with a tissue or coughing or sneezing into your elbow is important. But it's not going to just hang around in the air kind of indefinitely. What if you need to go to the doctor or hospital? One of the things that we've become increasingly concerned about is the fact that people have been avoiding the doctor and the hospital even when they really need to go. And part of that is because of the pictures that were coming out of New York City of showing us that the hospitals were overrun and that you'd wind up on a line and you'd certainly get infected. And the truth is that in Massachusetts, we still do have we're at what we call the plateau of the surge, meaning we've had a lot of patients come into the hospital and they're still sort of hanging out there. But if you were to walk into most of the hospitals and in the Commonwealth of Massachusetts, you would find the hallways looking more like the picture that's there on the left, that patients are tucked away into the inpatient wards and even the intensive care units. But if you come to our emergency room or our outpatient settings, it's really very quiet because all other patients are, we're not doing elective surgeries, we're not seeing patients routinely. And so it really is important that if you need to go to the doctor, you do go. If what we found is that people are putting off going for abdominal pain and letting appendicitis go too long. They're waiting and not going for heart attacks. They're not going for things that really need attention. And I have to tell you that I think this is actually the safest time to come to the hospital in many respects, because we're all wearing masks, we're cleaning excessively, and there are so few people in the hallways and around. What about testing for COVID? How does that happen, and what are we testing for? And mostly you've seen pictures of this testing happening where you stay in your car and you get tested, and that is how most of the testing is still getting done. You've also heard that there's two kinds of tests. One is the antigen testing versus antibody testing. And what does that mean? Antigens are what is the fancy word for the virus particles itself that cause the disease. So when we're doing antigen testing, we're testing to see, are you sick now? Antibodies are what our bodies make to fight infection. And so when we're looking to see if you've had it or if you've had a vaccine to it, if you're immune, that's when we're looking for antibodies, two different tests. So the test that mostly you're looking to get right now is an antigen test. Do I have the disease right now? And the way we do that test in most settings is we actually have to put a Q-tip into your nose to the back into your throat area. It's a really tiny Q-tip, but I'm not gonna lie, it's uncomfortable. And we do this with kids too. There are other forms of testing available in terms of swabbing through your throat, and some in terms of just getting saliva or stuff from inside your nose. Those are not as available. And so if you get tested, you are most likely to wind up with this kind of a test. It doesn't hurt, but I have to say it's not particularly comfortable either. And if you have to bring a child to be tested, you're going to need some kind of help, because kids don't like to sit still while we do this. Antibody testing is not widely available yet, but this is the test to see if you've had the disease before. That's a blood test. And so they're probably going to do that by drive-through means as well eventually. But antibody testing is not something that is offered everywhere by your doctor. There are a few sites that are offering it, but that's in general not the test that people are getting right now. And one of the problems is that they're still trying to identify the most accurate ways of knowing if you've got antibodies. Because if this test either tells you that you do have antibodies when you don't, or says that you don't have antibodies when you do, even in small percentages, it becomes much less useful to us, because it has to be really accurate for us to feel comfortable that we can act on that information. And what that test is supposed to be telling us is whether you have immunity. And you've probably heard of herd immunity. This is the idea that what we want to do is get enough people in our society protected, and you can be protected presumably if you've had the disease and gotten over it, so you've made your own antibodies, or you've gotten a vaccine and you've made antibodies in response to a vaccine. And the idea with herd immunity is that there will always be people who can't get vaccinated and who certainly should not get the disease, the elderly, the very young. And what we want to do is protect people who can't be vaccinated or shouldn't get the disease, because what would happen then if anybody did catch it, most of the people they would run into would be people who were protected by their own immunity, so they wouldn't pass it on. So anybody else who is vulnerable would be protected by that sort of shield of people who were immune. Now, what we have, and this is another picture of the same idea, and the idea is that this unvaccinated, vulnerable individual is then protected because there's a community of people who are vaccinated or who have caught the disease already, who have immunity to that disease. How do you get that immune antibodies is, as I've mentioned, you can get the disease, but in general, we're afraid to let too many people get it because it's too dangerous for some people. And the other option is that we get a vaccine, but that's not ready yet. About a week or so ago, you also may have heard that the WHO and CDC really are exercising caution because they're not 100% sure that the disease or vaccine will work to provide immunity. And I'm sure if you heard this, you're like, what are you talking about? I thought the whole point was that we all had to get this immunity to make sure we were protected. Well, here's the tricky bit. You know, most diseases, if you catch them, you're immune to them ever after. And for most of those diseases, we've created vaccines, things like diphtheria and whooping cough and polio and measles. All of those diseases, if you either get the disease or get the vaccine, you're protected ever after. Your body makes antibody and it protects you. There are some diseases where you make antibody to fight off the disease, but you don't make what's called memory antibodies, meaning they don't hang around in your body for a long period of time. They kind of go away. And so if you see the disease again, your body doesn't recognize that you had it. They are not 100% sure that this disease will cause the type of antibodies to be made that hang out for a long time, or these memory antibodies in your body. There are some diseases, and you may have heard of RSV, or respiratory syncytial virus. That's one of those diseases that you can get again and again and again because you don't make enough of these memory antibodies. So this issue, the jury's still out, and we're moving forward and trying to make a vaccine, and we're kind of thinking that if you get it, you're probably protected. But when you hear people say, but we're not sure, that's why they're not sure. Okay, so what can we do to protect ourselves? And lately you've heard a whole lot about masks, all different kinds of masks. And now that we should wear masks when we go outside, probably not cabbage, but masks that are either made out of cloth or surgical masks. And the truth is, what is a mask doing? A mask is doing two things. One is it's protecting your respiratory droplets from getting out, and it's protecting you from getting respiratory droplets that hit your nose and mouth. And it's also kind of protecting you from touching your face and putting those things by your nose and mouth. So what are some facts about face masks that you should follow? It should fit snugly but comfortably against the side of your face and be secured with either ties or ear loops. It's better if it includes multiple layers of fabric, but it has to allow for breathing without restriction. So if this is something that because of a breathing problem you have, and it's going to cause you to not be able to breathe okay, then don't wear the mask. It should also be able to be laundered and machine dried without damage to its shape and its usability. And the reason we say that is if I go out, and it's not so much that I have to protect myself from my own secretions the next day, but I want to wash the outside of it in case I came into contact with someone whose respiratory droplets hit my mask, and now I don't want to be exposed to those again. So being able to throw this in the washing machine is the best idea. Can you put masks on kids? Yep, you can. In general, we say that you can use masks on children over age 2. Under age 2, we do not recommend masks, but you guys know as well as I do that kids won't necessarily keep the mask on. So can you keep it on a kid any magical way? No, not really. You really have to just work with the child. And honestly, until a kid is probably about 6 or 7, it's awfully hard to get them to keep the mask on. What about kids who have some symptoms that overlap with COVID? Because to be honest, I gave you a list that is probably true about most kid illnesses. I said the most top 3, fever, cough, and maybe some difficulty breathing. So for a kid with asthma, that's kind of all their symptoms all the time. And so what do we do for kids who have some symptoms? And the answer is, if they seem like they're what I would call regular sick where you can keep them home, you can give them some fluids, you can keep them in bed or resting, that's what you should do. Keep them home and nurse them at home. If at any point you worry that maybe they should see a doctor, absolutely call the doctor. And there's some other things you can do to try and keep yourself and the family a little bit safer. Those first 3 things about washing your hands often, avoid touching your nose, and covering your cough or sneeze with tissues or the elbow. But the other thing you can do is try to separate as much as you can in the house. You know, of course, the littler the kid, the harder it is to separate. And when they're sick, they want to be held. And I get that. If you can wear a mask while you do that, that's great. You want to avoid sharing personal household items like dishes or eating utensils, towels, and bedding, things that the respiratory droplets can get on that you don't want to then put into someone else's mouth. And you want to clean all high-touch surfaces with household cleaner at least once a day: counters, tabletops, doorknobs, phones, bathroom fixtures. Again, because those respiratory droplets tend to fall, hit those surfaces, and that's where they will stay. How long will they stay on those surfaces? 2 hours, 4 hours, six, no, if it's hot, maybe if it's cold, moist, no. Honestly, it depends on the temperature. It depends on the surface. It depends on a lot of factors that are not measured in your house under scientific conditions. So the truth is we just have to clean the surfaces because we don't have a great answer for you on how long it's going to last on any given surface in your house. I'm often asked these days, what about kids that leave home or a program and then come back? Certainly our teenagers do this. And we've always had some concerns about those kids, and we still have those usual concerns. Did they get into something while they were out that we need to know about? Were they using drugs? Were they drinking alcohol? Were they having unprotected sex? Those kinds of things. But now we have some new concerns with COVID-19. When those kids come back, what can you do to keep everyone safe? And the answer is the same things that we talked about: the hand washing, the keeping a mask on, the washing surfaces, the distancing. If a child has symptoms, you certainly can treat them like you would, as I mentioned. If they are not particularly sick, they can stay home. If they're sick enough to see a doctor, they should. But the question I get asked most often is, can we get them tested? Still not that easy to get testing done. It can be done, but one of the other problems is that being tested when you don't have symptoms tends to lead to what we call a false negative. So remember I mentioned that you can have this period of time, 1 to 14 days, where you can have the virus, no symptoms, and still be spreading it. The problem is that in that window, you also are not getting the most accurate antigen tests back.
So one of the questions that came in prior to our little interruption here. Hi, everyone. Sorry about that. There was a question that came in about some emergency childcare centers that are operating still in Massachusetts, and, you know, some different practices in regards to kids in masks, which you just touched on. Some are really wanting kids, 3 and under to be wearing masks. Obviously, for the reasons that you touched on, that's not always possible. Do you have any knowledge about what currently, like if there are any AP guidelines or recommendations around kids in group settings and what age really they need to be wearing masks, or, in thinking about kids going back to group settings? Is there any information about that?
Right. So, the group setting policies are still being developed because we haven't been allowed to be in group settings too much, except for these emergency settings. The AAP is clear that under 2, we should not be doing masks. The kids just really can't handle it. And beyond that, the recommendations from the American Academy of Pediatrics and pediatricians in general have to do with the child's tolerance for it. And if in any circumstance it's limiting their breathing, you got to. So if you have a child who has asthma, or even someone who gets a little panicky with having the mask on, you got to stop, because the risk of not being able to breathe is obviously more concerning to us than the possibility of spreading disease. One of the things I would have mentioned a minute later in this presentation is the idea that what we think is that kids are mostly catching the disease from adults in the household who have it, rather than the opposite. With the flu, it turns out it's the opposite. Most of the flu is actually spread by kids, but COVID appears to be spread by adults to kids. So kids are probably not our biggest spreaders, we think. Again, we think. And I honestly have to keep saying everything about this is in evolution, but the evidence that we have coming out of the other countries that have been studying this, it looks like kids are not the harbors, but when we see kids who have it, they've been around adults who've had it, not the other way around.
Okay, that's helpful. Is there, you had mentioned when you went over the antigen testing and the antibody testing, what is the efficacy rate for the antigen testing if you are symptomatic? Is it 100%?
Not 100%, but it is pretty good. It's in the high 90s, so we feel pretty confident. It can do a couple people get through where we've tested and they test negative, but boy, we really think they have it. Yeah, we'll usually test you again if we think that that's the case. But that's a pretty accurate test. We're getting some very good results on that one.
Okay.
Can you get it again?
Yeah. Do you know of cases in the medical world where folks have already had COVID-19 more than once?
Yeah, so that's one of our big questions, right? And that's what led to that question of, are we making immunity that lasts? And so what happened is that there was some suggestion that we had seen a couple cases where people appeared to get it twice. That is really still being tested. We have not had a big enough cohorts for us to look at it accurately enough and to look into that, which is why a couple weeks ago, the WHO and the CDC said, wait, we don't know. And that's mostly their messaging right now is, we're not sure. We think you probably can't.
Right.
That's what we're not.
All right. One question that came in from an attendee is wondering about a child who tested positive for the flu at the end of February.
Mm-hmm.
Would it have been possible to test positive for the flu, but it was actually COVID? Are those two very separate and different?
No. Yeah, very different, actually. So if you tested positive for the flu, you had the flu. It's a different virus. We were looking for the different virus material. And so we can be sure, even now, when we test for COVID, we're often doing it, and at least, especially as we were doing this earlier on, even more flu. The flu is really down. But earlier in the season, like in March, when we starting to see COVID, we were often testing for both. And we were seeing flu in many cases. It was just the flu.
Okay. Great. And so we talked about the 14-day quarantine period for that 14-day kind of incubation period of not knowing if somebody could become symptomatic. Once they are symptomatic, does that 14-day window restart, or is there a different time frame for when somebody remains contagious when they have the virus?
So the question you're asking really is, when you become symptomatic, how do you know when you're no longer going to be able to spread it?
Mm-hmm.
So the answer is that you have to be symptom-free, fever-free for at least 48 to 72 hours. For us to feel confident that you are. There are some agencies, some jobs that ask you to have a longer period. There are some places where you can't go back to work until you test negative. But in general, once you're symptom-free for 48 to 72 hours, we're pretty confident that you're not spreading it anymore. It has to be all your symptoms, though. You can't, you can't still have a little bit of a fever. Now, can you still be coughing a little bit? Yeah, probably, because the cough can linger. But the fever, the body aches, the rest of those symptoms should be gone. To be 100% sure, you do have to be tested again, which is why some employers, like healthcare facilities, are asking that you be tested again to be sure that you're negative if you've had it before they'll let you go out again.
Okay. Thank you. We have another question asking if you can talk a little bit about the use of gloves and what is the most appropriate way to use gloves. Are they really necessary as part of protection efforts?
Yeah, gloves are really like another option for washing your hands. One of the things I've seen with gloves is that the gloves get dirtier. People are doing more with the gloves on. They have sort of this false sense of protection by putting gloves on. And in fact, the gloves protect you. Yeah, they protect it from getting on your hands. But the risk isn't to your hands. The risk is that it's going to go to your face. So if I have gloves on, I'm touching something, and then I put my gloved hands to my face, I haven't done myself any benefit, right? The gloves haven't helped me at all. So do you have to have gloves? No, because if you do something where you touch a surface and then you wash them or you use hand sanitizer, that's going to kill it. The glove would be an alternative too. So suppose I was going to do something where I knew I couldn't wash my hands, but I could use gloves. Maybe I was going to take a child to a bathroom where they, like on a road trip and they didn't have running water. That's where you want to use your gloves. But in other circumstances, just washing those hands is a really good idea. We do use gloves in the medical setting because we know we're touching infected people and we're trying to keep an extra layer on. And we're also going through very specific procedures about how we unglove, right? Because if I take those gloves off and the glove then kind of rips back and gets all over on my hand, again, haven't done myself any service. So if I'm going to work with someone who's sick, I actually have a whole procedure in my, it's called donning and doffing, where I put on my protective equipment and I take it off in a particular way so I don't get the virus on me. I'm still actually going to sanitize my hands. So in every regular, everyday life, do gloves offer me a big advantage? Not so much. That's why the masks are getting a lot more attention than the gloves.
Okay. Thank you. What would you recommend? You had mentioned children who are symptomatic being managed at home safely as long as they can be. What would you say are the biggest indicators that a child's moved their symptoms from okay to be managed at home to needing to see a medical professional?
In my experience, it's when mom or dad feels uncomfortable. When you get to the place where you're like, I need someone to look at this child. Then come. If this child's had a fever for usually over 48 hours and it's been high the whole time, depending on the age of the child, if the child's 13, it's a little different than if the child's 2. If the child certainly has difficulty breathing, absolutely bring them in. If there's a child you know has asthma and you've tried using the asthma medications, they're not helping this child, bring them in. If you have a child that's looking sick to you, boy, this kid just does not look okay. They're not eating, they're not peeing, they're just laying like a limp rag doll, it's time to bring them in. My experience is that parents have a really good radar, and we would absolutely be much happier for you to come to us and for us to say, I think we're okay, than for you to wait longer and not come. And so we still do want to see the sick kids.
Okay. Great. We have a few questions about more elective type procedures for kids. And what are your thoughts or recommendations about continuing to postpone? There's one child in particular who's scheduled to have adenoids removed, and another child who is scheduled for an overnight stay to rule out frontal lobe epilepsy. How should parents be considering what would be an appropriate time to move forward with these procedures?
Well, the hospitals are actually, right now, those things in Massachusetts are still on hold. So we're not doing them yet. But we'll be opening up to start to do those in the next few weeks. Yes, slowly. I can assure you that the hospitals are really taking every precaution and thinking about this very carefully. How many patients can we handle at a time? How are we going to prioritize who comes in first? And that the safety of the patients coming into the hospital is really uppermost on everyone's mind. As I mentioned to you, I actually think it's a pretty safe time to come to the hospital. I feel pretty confident every time I'm there that this is about the least infectious a hospital can possibly be. So while we never can get to risk being zero, I would listen to your healthcare provider, talk to them about what the hospital or the surgery center that you're using is planning to do. And most of the time, I think you'll be reassured that they're taking every precaution to make sure that they're not bringing you in until it is safe. I was just about to cover in my slides the fact that one of the things that we have found parents have been putting off that we really don't want to put off are vaccines. And most pediatric providers have found ways to do that safely, where we're bringing kids in for vaccines at a different time of day than kids who are sick. And especially for the kids who are under 18 months, making sure that we're getting them their vaccines in a regular time is really so important. How awful would it be if we avoided COVID for all these kids and then had this resurgence of whooping cough or some awful vaccine preventable disease? We would have done ourselves no service. So we really are still recommending that kids come in for vaccines, and most pediatric practices are still making accommodations, especially for the youngest kids, to do that. For older kids, we have a lot of wiggle room. You know, then you get a lot of vaccines until you're about 18 months, and then you kind of get a break. And the next set comes sometime between 4 years and 6 years. So if you're already 4.5, can you wait till you're 5? Yeah. If you're ready for your 11-year-old shots, but you don't get them until you're 11.5, okay. But for those little kids, we really want to get them in for their vaccines.
Okay. Great. Thank you. A few more questions we have. There's a few coming in regards to your medical opinion when it comes to keeping distance. So you had mentioned that the governor is starting to roll out some ideas of reopening at different stages. And I think a lot of family members are feeling, or a lot of families are feeling, that we've been isolated to ourselves for the last 8 weeks. And we have family members who have been isolated to themselves for the last 8 weeks. And if we're all asymptomatic, is there harm to getting together if we, at this point, if we stay 10 feet away, if we, try and follow the rules, how should families be thinking about the fact that we've all now been distant, and is there some considerations to make in terms of when you can see other family members, either here or in other parts of the country?
Yeah, I think this is exactly what we're all thinking about now. What is the safe way for us to move out of isolation and back into circulation with each other? Because we need to see each other again, folks. And that's what the governor is talking about. He's already brought up the fact that we want to do social distancing, right? Those respiratory droplets in general travel 3 feet, which is why we've doubled it to 6 feet. So if you can stay 6 feet apart, that's great. You can put a mask on, even better. And there's even more and more data coming out showing that these masks make a huge difference. So even if the kids can't keep masks on, making sure that the adults do. And using those precautions and washing hands frequently, those are going to be our first steps out and into a safe accommodations with each other. Can you go fishing together if you stand 6 feet apart? Yeah, probably. Should you be playing basketball where you're kind of up and licking each other?
Right. Thank you. Does alcohol-based hand sanitizer kill COVID-19?
Yeah, we think it does. Yeah, again, it has to be on and rubbed for those 20 seconds so that you have enough time to kill it and get the back of your hands and in between. But yeah, we think that the alcohol-based sanitizer does kill it quite effectively.
Great. Great. What is the latest medical information regarding ibuprofen and COVID-19?
Actually, you should not be afraid of ibuprofen. We do not have really studies that show that it is actually causing a problem. There were some rare case reports that came out, and they have not been backed up by really much study at all. And so the benefits of ibuprofen, especially with a kid with fever, man, I have 5 kids of my own. God bless ibuprofen. You need ibuprofen, you can feel safe that you can use ibuprofen.
Great. Thank you. How important would you say is blood and plasma donation right now? If someone's a regular donator, is there a real high risk to going into these donation centers, or should we think of them as we think of doctor's office in terms of their cleanliness and their efforts to get folks in safely?
Yeah, they've been doing a great job at trying to make sure that they keep everything really safe and clean in the donation centers. And blood products are desperately needed. All of those blood drives that we normally have couldn't happen. So we are in desperate need of blood products. So if you're someone that can regularly donate, now is an especially important time to do so. If you feel well enough to do it, we would encourage you to do so.
Great. Great. A lot of these questions they're great. They're all, some of them follow along the same lines. One other question we have about the vaccines, which we know are not ready yet.
No.
Do you think that as a vaccine becomes available, will there still be some enhanced recommendations around precautions, or do we think that we might be able to go back to some semblance of pre-COVID if a vaccine's delivered?
I wish I could tell the future. February, wow, what would I have known, right? Certainly, if it's true that we can get immunity from a vaccine and a vaccine becomes available, wow, that's going to make it's going to be a game changer.
Right.
And it will be available to all of us in the quantities that it needs to be. It's still going to be a while. In the meantime, are we really going to need to continue to do these things with masks and distancing? I think that's with us for quite some time. One of the things that I think is really interesting is that I started medical school before the HIV days. We didn't use gloves to do blood draws. We just didn't think of it. And now, wow, we would never think twice about doing that. The idea of using masks, I think, is going to become something that becomes a much bigger part of how we do all types of interactions, especially within healthcare. That may be with us for a while, and maybe even here to stay.
Okay. We have a few questions about resources that we may save till the end of your presentation. One last question I will give to you now. So as folks are starting to think about following the governor's recommendation about stepping forward in some ways to rejoining some parts of what we used to do. In the beginning of COVID, there seemed to be a lot of guidance around how to make determinations for yourself about who you should allow in your home, who should, before there was a stay-at-home order, questions about had you traveled, are you symptomatic? Do you have something similar that families can think about in terms of them making decisions about visiting dentist office as the dentist office reopen, or kind of going for outpatient physical therapy as they reopen? I think some families are looking for some guidance about how they themselves can decide if they feel safe enough to go out and to make use of these different services.
So there's two issues there, right? What are you bringing to those places, and what are those places risking to you? I think what the governor is trying to do is he's talking about 4 phases of reopening to make sure that they've put in place for each type of setting the precautions that are necessary for that setting. So it's going to be different at the grocery store than the hairdresser than the dentist's office. And each one of those places is going to have a different layer of protection, right? The dentist is obviously going to have a much higher level of protection for you and for them than the grocery store. So I think that's one of the nice things about our state, is that we're having a very carefully thought out plan going into this. What about your decisions for who comes to your house, and what about you guys going out? It still remains very important that you monitor your family members for being sick, right? So if anyone develops those symptoms that I listed, those are reasons to stay home. Those are reasons you don't want to bring this out. If you get into a situation and you notice that, hey, my kid is playing with another kid and this kid doesn't look good, this kid's coughing, it might be time to stop the play date and pull back. So I think you are going to start to see some of these same kinds of recommendations coming forward in the next few weeks. Do we have them ready to go yet? No, but I think what you can apply is sort of some of the same ideas, exactly as you brought that question to us. We had these ideas before we started. Yeah, go back to implementing those. If you have a fever, if you have a cough, if you don't feel well, if you're starting to have shaking chills, don't go out. Don't let the family members go out. And if people who have those symptoms want to come in your house, maybe not today.
Great, thank you so much. There are a few more, but I think they're questions that we can save to the end. So if you want to go ahead, Dr. Forkey, and continue with your presentation.
Sure. So let's go back and find where we were. I think I'll add a couple of quick things. You know, one of the nice things that's happened with medical care in COVID is that your doctor's office has learned how to do telehealth, and that some offices are doing it entirely through video, but most places also have telephone visits available to you as well. So when you call the doctor's office, you may feel like, hey, I don't really want to go there, and they may be able to offer you another alternative, because this has become something that pretty much every office can handle now. And this is what I mentioned about making sure that we do the vaccines. You know, as we think about COVID and kids in foster care, obviously this is a huge issue, but the care of kids who are in foster care is an issue all the time. You know, there have been a number of studies of kids who are in foster care, and we know that these kids tend to be sicker than their same aged peer kids. Up to 60 to 92%, depending on the study, have at least one chronic health problem. 25 to 40% have 3 or more health problems. A quarter to a third will fail vision or hearing screens. 40% started off as low birth weight or premature, and yet obesity rates for this population are twice as high as their peers. 30 to 60% have a developmental disability, and up to 85% have some mental health diagnosis. But we know that all of those things are related to the traumas that these kids have experienced. And so we wind up with an additive effect that we've had these health issues, and then we've got these trauma issues that are both causing and being caused by all of the things coming together. And just last month, a study came out which showed that kids in foster care are 42% more likely to die than kids in the general population. And this isn't meant to scare you, but it is meant to point out that these kids do need attention from doctors at a much more, with much more attention. And that healthcare really requires a lot of coordination of the foster families, but also involving a lot of times the bio family, the mental health provider, the medical providers, early intervention, the schools, the courts, child welfare. And we want to make sure that they get healthcare more frequently. So there are recommendations from the American Academy of Pediatrics and the Child Welfare League of America that these kids should get more frequent health care. So normally for kids 0 to 6 months, we do every 2-month visits, but for these kids, we should do it monthly. For kids who are not in foster care, we recommend being seen every 6 months when you're between 6 months and 2 years old. But for kids in foster care, it should be every 3 months. And for your over 2-year-old kids, we usually say, come see us once a year, but for kids in foster care, it should probably be at least twice a year. And a lot of it has to do with information management. How do you get that information about your child, and how do you get it to the people who need it? And part of the problem is that having the accurate records becomes so tricky. So making sure that you have your own contact person in the child welfare office, and even a bat phone or a person to contact that you can work with. You know, every DCF office now has a medical social worker. Knowing who they are, how to contact them is a really important piece of how you can help keep your child healthy, because it's their job to work with you and with their child welfare worker to make sure that happens. What we know is that foster parents are often frustrated by the lack of medical information they have, the unique needs of these kids, having to get the information themselves, and needing support with things that should be routine. They have to fight for things that should be automatic. And so what we want to say is there's a lot of stuff out there that's just not true. You know, many times foster parents say, well, I'm not allowed to have that information. And the truth is you are. Bio parents' health history is confidential. The bio parent may choose to share it with you, but you don't have privy to that information. But the child's medical history needs to be known to you so that you can care for the child. And it also has to be known to the child welfare worker and to the doctor so we can do that work. And so the truth is that the rules allow you to have health information. Now, can you just get a whole copy of the child's hospital records? No. HIPAA rules prevent you from sort of just walking in and saying, I'm their foster parent, let me have it. But getting the right consents from the Department of Children and Families allows you to get health information about this child. And so you should make sure that no one ever tells you that you cannot be told about that child's health information. It is recommended that kids be seen before they've been in care for 7 days. And it can be really helpful to work with a medical provider who knows that you're a foster parent so that you have access to that. We have the foster care clinic or the FACES clinic at UMass, and that's an important part of what we do is make sure that we have access all the time so that people can get in to see us within that 7 days. I think it's also worth pointing out that for kids who are coming into care, coming to the doctor can have a whole overlay that you may not think of automatically. And certainly as a doctor, I think of myself as kind and loving and our place as being a supportive place. But this is, there was a story written called City of One by a woman who's a psychiatrist in New York City who was in foster care. And she wrote about her first medical evaluation and how she felt like she was a horse and they were checking her hooves and teeth. And I've certainly been in situations where people have said, you're going to the doctor so we can find out what's wrong with you. You know, kids often have a perception that they've come into foster care because there is something wrong with them. And coming to the doctor shouldn't reinforce that feeling for them. And we're going to do our very best to make sure that they know that they've come to the doctor so we can show them how healthy they are. And so reinforcing that for kids. We're going to do a whole bunch of things to make sure that they are healthy. So let me quickly run through with you what we're going to look for. We're going to look at height, weight, and blood pressure. We know that these kids are more likely to have issues with both failure to thrive or obesity. You know, one of the things that happens when you've experienced a lot of trauma is that your brain thinks that you're being chased by a tiger. And if you're being chased by a tiger, your brain shuts off your feeling of fullness, so you keep eating so you have enough calories to keep running. And so it's not uncommon for us to see weight issues for these kids where they have a lack of feeling of fullness. Foster parents talk to me all the time about how the child keeps eating. And sometimes we think that's food insecurity, but often it's just the traumas that these kids have been through. Certainly there's a lot of urgent things we may need to identify within those first 7 days. Do they have mental health concerns where they're going to be overacting or reacting in the house? Are they threatening to hurt themselves? And are there signs of injury that you need to know about? Do they also have signs of illness or injury, or do they have health needs that need equipment or medication that you need to have access to? Dental concerns are often the hugest ones. And sometimes people say, oh, well, it's just the teeth. But you got to remember that the teeth sit in the head and have direct access through those roots of the teeth goes right to the brain. So dental decay and abscesses can actually turn into very serious brain infections if we don't catch them. So dental concerns are, for me, a very big issue. For babies, we want to know what they've been exposed to so that you can help care for them in the most effective way. And if a child comes to you with medications, you want to know what the medication's for and how to give it. I just had a family who came to us in the middle of COVID with 2 prescriptions, one a medicine to help the child sleep, and one a medicine to help the child with ADHD. But the prescriptions were not labeled, that one was for night and one was for the morning. And so she was giving them the opposite way. And so this was a child who was sleeping all day and awake all night because the medications were not labeled appropriately and she didn't know what they were for. Getting the equipment these kids need. You know, I had mentioned to you that 1/4 to 1/3 have hearing or vision problems. Now, when you're trying to work on school, if you don't know that they need glasses or a hearing aid, that's going to make schooling pretty hard. Do they need equipment for things like cerebral palsy or their asthma that we can help you get? And really, coming to the doctor just gives you that first resource so you know something about these kids. You know, I often find that kids don't get dropped off at the sleepover with less information than they'll come to you about their health. So starting those visits early with the doc so you can have the information you need is so important. We also recommend that they get more comprehensive evaluations within a month, and those will cover a number of issues. But one of the most important things is that the physical exam needs to be totally complete. You know, we talk about how so much information comes from history, but for these kids, there's going to be big gaps in the history that you have and the things that you know. Working with bio parents can certainly help to fill in those gaps, but doing a complete unclothed exam is so important that we really understand what's going on for these kids' bodies and their health. Oops. Also thinking about vaccines. Many times these kids come without vaccine records, but have actually been vaccinated. And while it won't really hurt them to get more vaccines, it's kind of mean to give them vaccines that they don't really need. And as I mentioned, getting those hearing and vision tests is so important for these kids who have such a high likelihood of having hearing and vision problems. Getting developmental evaluations is important because these kids often have experienced things that have impacted their ability to do well in preschool and in school. And many times people come to me and say, hey, can you test this child for what drugs they've been exposed to? We certainly ask questions that get at whether there might be some substance use issues, but we don't generally secretly test their urine, because if we are going to find something in it, we're going to want to build some trust with the kids. And if we've tricked them into doing a urine test, that's not the first step in building trust. So we talk about what drugs might you be using and why might you be using them. Many times these kids have been living in really tough situations, and if they've been using drugs, it's a way to kind of medicate themselves, calm their anxiety, or deal with the stress. And so we're going to want to try and do that in more effective ways and talk about why they might have been using those drugs in the first place. There's some blood tests that we're going to want to check for these kids, making sure that we check their blood count. Have they been exposed to things like tuberculosis? And have they been in situations where they might have high lead levels? Also thinking about things that kids can have depending on their experience. If they've been sexually abused or potentially exposed to some of these disorders from in utero, we want to check for HIV and hepatitis, syphilis. We want to check urine for chlamydia and gonorrhea and trichomonas. And some kids we need to check for pregnancy. Some kids who are overweight, we're going to check for high lipids or diabetes. There are vaccines we're going to need to update, and pretty soon we're going to have to add COVID to that list. And then many of these kids have had experiences, either sexual abuse or really just the neglect and the emotional abuse that has put them at risk for early initiation of sexual activity. And making sure that you're comfortable and are able to have those conversations with the kids, because oftentimes child welfare doesn't have a policy about who's going to do that for these kids. And having a partner in your healthcare provider who can do that with you. Working on thinking about those things that help make kids' lives whole, their sports, their activities, those normalizing activities that make kids thrive, and how your doctor can help you to make sure that kids are getting that done. Also recognizing the times of stress for these kids that are not in every kid's life, like going to court and how to prepare for that with your child and how to manage it if court doesn't go as everyone expected it to. Especially important are those visits with bio parents, which are so hard now, where you're doing so much on the electronic media and they're not able to see the parents. Thinking about ways to normalize it for kids, where we can set up, we have little books that we do with kids. I'm going on a visit. So you can read it before they go. So you can set up how it's going to go, because going on a visit can be so disruptive to a kid's understanding of where they're going to be safe and what's going to happen for them. And if a visit doesn't happen, they can even get more upset. So coming up with some tricks for how to manage it both before and after visits, and if visits don't happen. You know, right now, all our lives are really disrupted. And if you add on to the top of that, not being able to see your bio parent, having to do everything on the phone, timelines that have gone all kablooey on all of us, how do we help kids in the moment? And really working with your doctor on those issues is important, but if I could give you one quick way to remember some things to do, I'd say it's the 3 R's: reassure, restore routine, and regulate. The more you can tell these kids that they are safe, they are safe, they are safe. You can do it with words, but you can also do it with touch. You can do it with making a tent for their room. You can do it with extra blankets on their bed. But a lot of times, they're going to act out in anger because they feel danger. And there's a reason why the word anger is embedded in danger. Making sure that you say to them, you are safe here, you are safe here, you are safe here, is so incredibly important as they work toward feeling better. Teaching relaxation techniques and using all 5 senses, listening to music that calms them, doing some meditation, using some scrunchy things that they can hold in their hands, smelly salts, fireballs or ice that they can put in their mouth, all things to help make them feel safer. You know, we often also talk about stimulating parts of the body that calm us. When you rock back and forth, it stimulates your vestibular system, which is why being on a swing or dancing or sitting in a rocking chair can all help kids to feel calmer. Routines are so important for all of us to feel safe, and COVID has knocked all of our routines kablooey. If we as adults feel that, you can imagine the kids do too. So getting back on routines, making charts of routines, making routine the ways that you get back to getting kids calm. And that's not just routines for the day, but it's routines of positive interactions. And it's also really important that we think about regulating. You know, regulation or controlling your emotions has to do with understanding what the feeling is and the word for it. And a lot of times these kids come with not enough words or an understanding of what they feel. So often when kids get upset, we say to them, why are you so angry? But they're often not angry. If they haven't had a visit, maybe they're frustrated or worried about their bio parent, or maybe they feel disappointed or that guilt or grief about what's happened. And so beginning to think about how we can teach words to kids about what this emotion is and how to manage it. Sesame Street has some fabulous resources to use. If you haven't already downloaded Little Children, Big Challenges, Breathe, Think, Do, you should definitely put that app on your phone. I use it with big kids too. Using Elmo's belly breathing until that song is incessantly going through your head. And going to the Sesame Street website to look at all the Big Bird's Comfy Nest resources is another great thing to find. Making sure that the kids still get outside, and now that the weather is better, let them run, because burning off that energy is so, so important. And eventually using your doc to get the resources to get these kids evidence-based trauma therapy, that's so helpful. You don't want these kids just to go to any old therapy, but they need to get to evidence-based trauma therapies. And we have a whole host of them in Massachusetts. So I'm going to stop here and see if there are any more questions still.
There are a few. Thank you so much, Dr. Forkey. There are a couple of questions to follow up to your piece around just general health considerations for kids in care. There's a question about whether or not during the screening, doctors routinely check for head lice. And if they don't, is that a reasonable thing to ask?
Absolutely. Yep, that's an important thing to ask, because certainly that's not something you want in the house and not knowing about. So yes, usually the doctors will check, but doctors are human too and may get busy and may get to talking to you and forget. So it's absolutely and 100% okay to ask. And it's something that we're totally happy to do.
Great. Another general question is in regards to the HPV vaccine. Is that, in your opinion, a vaccine that's worth doing? And in your experience, is that a choice that foster parents can make for their kids, or is that something that DCF needs to weigh in on?
So the rule is that foster parents have the right to make routine health decisions for kids, and HPV is considered one of the routine vaccines for kids. And so yes, you guys should be getting that for the kids. HPV is an important vaccine for both boys and girls. It stands for human papillomavirus. We know it's the virus that causes cervical cancer, but it also is responsible for a lot of throat cancers. It's important that, and it's given usually between the ages of 9 and up, but usually we do it around 11. And it's an important one for us to get for kids, absolutely.
Great. And then there's just a few others that are more specific to COVID-19. One being in thinking forward to summer, which I think we all probably are at this point, in thinking about pools and other places that folks may congregate. Does chlorine keep down the risk of infection? Is there any other considerations about spending time in water in large groups to think about?
Yeah, so it's actually not the water that is so much the problem, because the chlorine will help. The issue is that the kids kind of do a lot of getting close to each other and chicken fighting and Marco Polo and swimming races where they're going to get close. So how we go forward with public pools, we'll have to find out. Again, thinking about this going forward is going to be important. It's not the pool so much I'm worried about. It's the rest of the activity that happens around the pool that's going to put us at higher risk.
Great. Great. And I think an important question that came in, we talked a lot about ways to help mitigate the spread of COVID-19, quarantining and kind of keeping folks separate, wiping down common touch surfaces. For foster parents who are considering bringing a child into their home newly during this time, who may have been exposed, who may not have been exposed, it's such a hard time for families to adjust anyway. If a foster family is taking in a new placement and they have a child who needs to be quarantined, do you have any thoughts about ways that families can make that a little easier on the child who's they themselves trying to adjust to a new family environment and the family is trying to adjust with them, but they're separate?
Sure. Yeah, there are so many issues with quarantining. Certainly certain kids at a certain age, they just can't be separated that far from adults. And as kids get older, you can do more separation. True quarantining means that you put a child in their own room and you have one dedicated person who passes them food, who carefully takes the food back. that's really tricky to do with a new child entering your home, and will certainly add to the isolation that child feels at a tough time when they're moving into a new setting. So thinking about ways that you can do things with distancing, with masks, with everybody washing hands a lot, are really those important, critical things that you can do. Can you guys share movies and things where you all have the same tablet? Can you guys play games that you can play at a distance? Can you guys do activities that don't require you to be in close proximity, but that can be done at a distance, where even potentially you guys go out in the backyard and this child can be a part of activity, just not up close with everyone? The truth is there's not a magic way for us to do this that is that much less painful. Distance is distance, and not touching is not touching. And, you know, I am so grateful to everyone who's been foster parenting through this time. I actually consider you guys the big heroes in all of this. That we in healthcare have gotten a lot of positive praise for all the work that we're doing, but you guys deserve just as much. And the work that you're doing is 24/7, and we get to go on shifts. So bravo to everyone who's continued to do foster parenting and even thought about it. For those who haven't been able to because of their own health risks, that's totally understandable. And we'll all get back to a time when everybody can do it again. So I think those are absolutely reasonable concerns.
Thank you, Dr. Forkey. There's a few questions about resources, and if you have any that you feel would be helpful to share for foster families specific to COVID-19, we'd love to hear about them. And then I can put in a little plug at the end for the resources MSPCC is trying to corral and make available to families as well.
Sure. So the American Academy of Pediatrics website has some really great resources, and will reinforce a lot of the things that I've talked about. The CDC also has resources and breaks them out by category. So if you're thinking about childcare or you're thinking about different settings, the CDC breaks it out by that as well. Another area that I would really strongly recommend that you look at is called the National Child Traumatic Stress Network. And you can Google COVID-19 resources, National Child Traumatic Stress Network. And they have a whole set of resources about how to talk to kids about COVID-19, how to deal with the stress that you and the kids are all feeling, and a myriad of issues that come. If a child's dealing with grief, if something's happened where they've lost someone, it's all in there as well. So those are my three favorites: American Academy of Pediatrics, CDC, and National Child Traumatic Stress Network.
Great. Thank you so much, Dr. Forkey. That is the majority of the questions that we had come into us this evening. I want to thank you again for your time, for rolling with our technological glitches so calmly and evenly. I can only imagine as a presenter that's a little tough to pick up from, so we appreciate that. And I want to let the folks at home know that we at MSPCC and KidsNet, we have our website, which we are continually updating with resources and trainings and support group opportunities, and that's at mspcc.org/kidsnet. There's a variety of resources there, and I encourage you to check in and contact your regional KidsNet director if you have questions, if you're in need of specific supports, if you have ideas for trainings or topics that you'd like to hear more about. Please feel free. All of the contact information is on the website. And again, we're trying to keep it regularly updated with not only information from DCF that would be helpful to you as you continue foster parenting during this time, but also ways to connect with one another and support one another's journey as we are making sense of all of this. So thank you. Thank you for spending your time with us tonight. And again, thank you so much to Dr. Forkey for your time and information.
You're welcome. Thank you guys. Thanks for all you guys do.
Have a great evening.
You too.